All right, well, October is Breast Cancer Awareness Month. And I hope you've either had your mammogram or scheduled your mammogram, or if someone in your life you know and you love hasn't, make sure that they do. So, we're talking about breast cancer today. It's a really important topic. So, if you want to know more about this, just stay tuned. Good morning, everyone, and welcome to Scan FYI. My guest today is Dr. Michael Simon. It is Breast Cancer Awareness Month. It's October, and Dr. Simon is a radiologist, and he specializes in breast imaging. So good morning, doctor, and thanks for being with me.
Good morning. Thank you for having me.
I think it's an important topic, and I would like you to just briefly introduce yourself, tell everyone a little bit about you, and what is a radiologist specializing in breast imaging?
For sure. I'm Michael Simon. A radiologist in general. We start residency, we do 4 years of just general radiology, but then we specialize in different fields. For myself, I specialized in breast imaging, which means you do 1 year of just dedicated breast imaging. All you read is images, mammograms, MRIs, ultrasounds. You perform biopsies, and once you complete that year, you then are able to go out into the real world and practice on your own. So that's what I did a few years ago, and now we're here. I'm at Robert Wood Johnson, very happy to be a part of this growing practice throughout the state of New Jersey, and I look forward to helping everyone understand more about what we do, why it's important to get mammograms, and so on and so forth.
And just in case anyone listening doesn't realize, the radiologist is the one who is reading your mammogram, correct?
Yes, so we are the ones reading your mammograms. We're the ones reading your ultrasounds and your breast MRIs. We're also, which some people may find this funny because everyone views radiologists as sitting in a dark room, but we are the ones who perform the biopsies as well. So we'll be the ones,
Okay.
if we see something suspicious, we'll be doing all the various breast biopsies. And we're the ones who will give the results of those biopsies, hopefully good news, but sometimes some more concerning news.
All right, so I think I'm glad you explained that because I always think that there are some people out there listening who might not understand the role of the radiologist in this whole process. So it is October, it is Breast Cancer Awareness Month, and sadly, it's very prevalent, isn't it?
Yeah, unfortunately, approximately 400,000 women every year in the US are diagnosed with breast cancer. It's estimated that 1 in 8 women in their lifetime will be diagnosed with breast cancer, which puts every woman at about a 13% risk, just at baseline, of developing breast cancer.
It's hard to believe that it is that prevalent. And it always makes me wonder, was it always out there this prevalent, or is it just that we're more aware of it now and we weren't aware of it many years ago?
So I think it's a combination. I think it was this prevalent years ago. I think we're living longer for longer periods of time.
Yes.
So we're picking up those extra cancers that might develop later on in life. We have better uh, diagnosing techniques, and we're able to pick up cancers earlier. So I think it appears that it's more prevalent, but at the same time, I think that it's still the same amount. It just appears that way. Although anecdotally, it does feel a little bit more.
But maybe we're just diagnosing more of it, which is a good thing. I'm guessing for some people years ago, it was undiagnosed.
Yeah, I mean, a lot of women might even have it when they pass away at 120 years old. They might have had breast cancer, but it was growing so slowly
Right.
that it didn't really affect their lifespan. But it probably I think the amount that we're diagnosing it's still the same amount as before overall.
So let's talk about early detection because, I mean, in my book, with anything, it's all about early detection.
Yes, 100%. And early detection is very important because the earlier we detect a cancer, the less amount of treatments an individual might need later on. if we're able to detect a cancer at the earliest stage, which would be a stage 0, they potentially a breast surgeon could just remove that small area, and whether or not they need additional treatments with radiation or getting chemotherapy or endocrine therapy, that would be based off of some of the tumor markers that are seen on the cancer cells by the pathologist. But doing a small surgery as opposed to removing the entire breast
Right.
is something that could help a patient's morbidity. It could also help their cosmesis, how they look, how they feel about themselves, and it could make a very big difference in their lives.
It's a really big difference in early detection when you find something and you just have to remove a little something versus not doing anything. And by the time you deal with it, it's like you have to remove your breast. So,
Right. It could remove your breast. It could have already spread to the lymph nodes. It could
right.
spread to other parts of the body, which at that point in time, once it spreads to other parts of the body, the liver, bones, then it's really not even operable. So it's very important to catch things early.
So, we mentioned this before we had the camera rolling, but it feels like yes, breast cancer. I always thought of it as something for you were older, and we were noting that now you've seen it in younger women.
Yeah, so interestingly, in our group, which is primarily based in South Jersey, we've had a number of cases where um, women as young as 25 were diagnosed with breast cancer. And that's not something that typically a woman of that age is looking for. So it's typically found a little bit later on, unfortunately, because they'll feel a palp. Once you feel a palp, that probably means that there's a mass there as opposed to small little calcifications. And then we look in the lymph nodes, and it might have already spread to the lymph nodes as well.
Right.
Um, in those cases, although it appears that it's more aggressive, oftentimes when it's not genetically linked, those cases are still very treatable. But we've had about 8 cases of what we call pregnancy-associated breast cancer, and that's breast cancer, which is associated with either a patient who's pregnant or within a year of a pregnancy. And that is something that's rare, but it is something that's important. And that's why even for women who feel something when they're in their 20s or in their early 30s, and it's not really recommended that they come in for a mammogram, we always recommend just come in, let us check it out, because it's
Right.
better to be on the safe side than, sorry, and something's worse happening.
Because you know your own body. So if something is wrong, deal with it. Deal with it now rather than deal with it later. Absolutely.
Right.
So, what are the screening recommendations? I mean, the more traditional, let's say.
Yeah. So the traditional recommendations are that starting at age 40, a woman should come in for a yearly screening mammogram. Depending on the density of their breast, there are 4 categories of density, and ranging from mostly fatty to very dense. And being very dense is a total normal, completely normal, especially for younger individuals. We might recommend that you get an ultrasound to supplement the mammogram, not to replace the mammogram. And that's a key difference because a lot of women come in just wanting the ultrasound, but the gold
Really?
standard, yeah, they're afraid of, there's there are these blogs out there that say that there's radiation to mammograms, and while there is radiation, saying that there is no radiation, that would be completely false. The amount of radiation, especially with our mammograms nowadays, are so negligible compared to what was potentially back in the day. But also, what I tell patients is if you take a cross-country flight to Los Angeles, I'm based in, as I might have mentioned, in New Jersey, the greater New York area. If you take a cross-country flight, the amount of radiation to your entire body is more than what you might be getting from a single mammogram. So if you're
Wow.
willing to take the risk to fly to LA, then you should be willing to take the risk to get a mammogram,
There
which
you
is
go.
it's not really a risk to make sure that you're healthy. So that's what we try to convince patients who are hesitant to get their mammograms.
So that whole thing about too much radiation, that's out the window.
In my opinion, it's out the
Yeah.
window. Probably there's some other underlying reasons, anxiety and so on
Oh,
and so
that. Yeah.
forth,
Well,
that might be
yeah.
at the
Yeah.
reason why patients are hesitant, which is understandable, but that's why we like having conversations with patients who are hesitant. If we could try to allay those fears, try to make them more comfortable. We're here to help. We're not here to force anything on anyone. So
Don't worry about the radiation. I'd rather have a smidge of radiation than, and find out something was wrong and deal with it immediately. I
yeah,
mean, I feel like that's really the way to go.
yes.
Who might be more at risk than, like given, there's a room full of people, who might be more at risk?
Yeah, so as we mentioned earlier, like the average risk woman is around 13% lifetime risk of developing breast cancer. But if you have a family history, if you have had radiation as a child, which you might have had if someone has had lymphoma or any chest radiation, which they often give for patients with those types of cancers. If you have some genetic mutations, the most commonly associated with the breast cancer are the BRCA
Mm-hmm.
mutations, both
Mm-hmm.
1 and 2, although there are other genetic mutations which do give an increased risk. And it just could be a combination of factors. We have special algorithms that are used not just in our practice, but throughout the country, where when a patient will come to our practice, they have a questionnaire that they fill out. And based off of when their menstrual cycle started, how many children they had, whether they nursed, family history, things like that, all that information goes into the algorithm, and then it gives us a percentage of their lifetime risk factor. And anyone who is above 20%, we consider high risk. And those patients will recommend, in addition to the yearly mammograms, to get MRIs as well, a breast MRI, a yearly breast MRI.
But I guess the biggest part of it is seeing the doctor in the first place and being honest about the whole, your family history, so the doctor knows your how to assess the risk.
That's 100% true. And that's why oftentimes OBGYNs, who I think women are more comfortable going to than potentially getting their mammograms, they also have these scoring systems, and they'll put it into their scoring systems. And they'll be able to find these women and let them know. It's not a perfect system. Not all OBGYNs do that. Not all of them have the same system or the same scoring system, but we try to capture as many women as possible to let them know, because knowledge is power. And our job is to give over as much information as possible for everyone to make the right decision and choices for themselves.
I can remember hearing many years ago where people said, well, genetics was a huge component. And if, your mother, your aunt, your grandmother, they had it, you're probably going to have it. And if no one in your family ever had it, you'll probably never have it. But I'm thinking none of that's true.
No, so if many members of your
Yeah.
family did have breast cancer, there might be an underlying genetic component that's causing it. But if no one has had breast cancer, that doesn't mean that you're not going to get it. I know of families where there was a genetic component and multiple siblings had like BRCA mutations. The mother had a BRCA mutation. They didn't know because by the time one of the children was diagnosed, they were in their 80s, and it wasn't necessarily worthwhile to test that individual for other reasons. But that was the only person who had breast cancer in the entire family. It was a very big shock that that person developed breast cancer. So just because no one else has had it does not mean that you're in the clear, unfortunately.
That's right. So again, another reason to schedule your mammogram.
Yes.
Because just because no one
Schedule.
else did, yeah, yeah, absolutely. So if you are genetically inclined, if that's even the right way to say it, but that doesn't, I don't want people to feel like it's going to happen to you. How do you find out about these genetic mutations that you may or may not have?
So typically we test for the genetic mutation only when there's a family history, or
That makes
specifically
sense.
with the BRCA 1 or 2, those of Ashkenazic Jewish descent, those are predominantly found in that population. So if you are of Ashkenazic Jewish heritage, then you might want to proactively get tested. Um, But with that being said, what I tell patients is all this is telling you is that you're at a higher percentage risk. You're typically, depending on which mutation, you're around 70%, which is by far much higher than the 13% of an average
Yeah.
risk woman. But that's
Yeah.
still a 70% chance that you'll get it in your lifetime, but also a 30% chance that you won't develop it. So just because you have the genetic mutation, it does not mean that you will definitely get breast cancer. It means that you have a higher chance of developing it, and we will be more aggressive in screening you and also in performing biopsies just to make sure that we're not missing anything to try and catch things early. But that does not mean that you will develop breast cancer. It's a misconception that a lot of patients have, mainly because of anxiety that they have this mutation or that they have a family risk. Nothing is 100%. There, until something's biopsy proven cancer, it does not mean that you will develop cancer in your lifetime.
So one last question that I'm curious. So you used to hear the expression I had a lump or something. It was precancerous. Now we hear stage 0.
Yes.
Has
Okay.
one replaced the other?
So not exactly. There's the precancerous could mean a few things. So that could be there were atypical cells, which lead to a higher risk of cancer because those cells will eventually develop into cancer. They're on the same pathway, and we leave them there. They most likely will continue to develop into a cancer.
Okay.
But stage 0 is defined as is specifically for a cancer called DCIS, which is called ductal carcinoma in situ, where the cancer cells are within the ducts that milk travels within the breast. Doesn't mean they're within all the ducts, it's within the ducts that were biopsied or that we saw the suspicious finding. And there's a lot of literature. I don't want to cause any misconceptions of whether that they're actually cancer. If we could watch them, some of those cells develop into more aggressive cancers and the like. But at the moment, the consensus is that we remove those. When we find that, we remove that, and we'll treat you with endocrine therapy or chemotherapy. And we'll, as a radiologist, once we make the diagnosis, we'll send you to a breast surgeon and to an
Hmm.
oncologist.
Okay.
Um, but there are cells, other types of atypical cells, which you don't really have to worry about because our research and the studies that have been published show that there's a less chance of them developing into a cancer. But those are very nuanced, and typically, as a radiologist, we'll still send you to a breast surgeon just to be evaluated and to have a conversation about whether to leave that in the breast and to do some high-risk screening or to surgically remove it.
Thank you for explaining that. Thank you very much. Well, I want to say thank you so much for being my guest today. It's October, it's Breast Cancer Awareness Month. If you haven't already scheduled your mammogram, just do it, make it happen. I will leave a phone number to schedule in the Barnabas system, Robert Wood Johnson Barnabas system, so that you can do that. But wherever you go, just make sure you go, right?
Yes, 100%. It's better to know than to not know.
That's right. That's right. Well, Dr. Simon, thank you for being my guest.
Thank you for having me. It's been a
It's my
fun time.
good. Well, I'm glad you enjoyed it. It's always, it's a rare treat to speak to an actual doctor. And, then I really feel like we're going to the source. And that's how I feel today. So that was great. Thank you. Remember out there, if it's important to you, it's important to us. I'm Andrea Tarr. We'll see you next time on Scan FYI. Bye, everyone. And bye, Dr. Simon.
Thank you for having me.